Good evening and welcome to our King's Talk with current Grange housemaster Mark Orders. As most of you know, my name is Greg Hunter and I'm the Deputy Head Co-Curricular here at King's. Mark tonight tells us his very personal story, presenting patient-driven innovation, building an artificial pancreas. Mark joined King's in 2009 as a physics teacher. He was head of middle school for 3 years and from 2014 has been the housemaster of the Grange. He was diagnosed with diabetes, type 1 diabetes, in the early 1990s, aged 10. He's been using the do-it-yourself OpenAPS system since 2018. And since 2021 has allowed all of his diabetes decisions to be made by an app on his smartphone. He's been working alongside the developers to support and mentor others around the world. And with NHS consultants, is keen to bring this to their patients in the UK. Please either type your question at any time in the Q&A function of Zoom, or alternately put your virtual hand up after the presentation, and we can put you on the air live to ask yourself the question yourself of Mark. I'm really looking forward to this presentation, and it's now with great pleasure that we hand over to Mark. Good evening, Mark.
Good evening, and thank you very much, Mr. Hunter, for allowing me to speak to you all. And thank you for coming along to hear what I have to say. This is a personal journey for me, a personal presentation. I'm not a doctor or an expert really in diabetes or the condition in any way. I'm not a coder, programmer. I am a patient. I am a person with diabetes, and I have discovered this for myself. And with the help of others. I am very open to answering any questions, speaking to anybody during or after the presentation. Part of the culture of the OpenAPS system is to pay it forward and to help others, and that's what I hope to do tonight. I also may not have all the answers, and if I haven't made any errors during the evening, please forgive me for that. So without further ado, let's start this. Before we begin talking about OpenAPS, I want to briefly mention diabetes and the two types, type 1, type 2. I have type 1 diabetes. 6% of the UK population has one form or another, and a minority of that 6% have type 1. Now, type 2 is a type of diabetes that's in the news quite a lot, often with unfavourable headlines such as this. I urge you to go and have a read about Tom Watson, for example, who's the Labour deputy leader, well, he was before the last election, and he was able to treat, or at least work towards treating, his type 2 diabetes through changes in diet and lifestyle, and that was a very interesting bit of research. I remember being quite inspired by what he said on television. But tonight I'll be talking about type 1 diabetes, specifically diabetes treated by insulin. And if you Google this, both types, in fact, you'll see all sorts of statistics and worrying headlines about the cost, about the side effects or the long-term implications of of having diabetes. Many complications exist of type 1. I've listed some there. There are many others, and they're all very concerning, especially as a patient or as a family member of somebody with diabetes. My diagnosis began very much like anyone else with type 1. I was young, I was about 10 years old. Here's me, 1993, very proud of the CD player you see there. And I started to wet the bed, drink lots of water, lost a lot of weight, became tired all the time, very weak. And my mum took me to the doctor, a blood test was performed, and when I went back in to get the results, I was told by the doctor, yes, he's positive, he has type 1 diabetes. And I was taken directly from that doctor's surgery, actually up to Peterborough Hospital, where I spent a week being introduced to this condition that I'd been diagnosed with. One of my diabetic friends, colleagues, refers to it as being struck by lightning, is that nobody can expect it to happen. And when it does, you're suddenly in a great deal of shock and worry and trouble, and life's never quite the same again. You're told that there's no cure, at least there won't be one for 10 years. That's what I was told in 1993. and you have this condition for life. And you're taken onto the ward and you begin your regime of injecting insulin. For me, it was a twice daily injection of insulin. Human mixtard 30 was the insulin I was on. It consisted of 2 types mixed together, and you would have the injection twice a day. The morning injection dealt with your breakfast and some of your lunch. The evening one dealt with your dinner and overnight. And this is ideal, provided you live a very rigid lifestyle, you eat exactly the same amount of food and do exactly the same amount of exercise. But this is what I was given, and this is how many people at that time began treating their diabetes. In the 80s and 70s and 60s, it was much more complicated, but this is my story from the early 90s, what I was presented with in hospital. I remember now 9 units in the morning and 9 units in the evening, with a glass of milk at break at school, I find myself going low at about the time when both insulins were working. This graph represents the activity of the insulin. And to keep an eye on things, you would do blood tests. First of all, with a colour chart, later on with a computer, which you would plug the blood test strip in and record the value. These were quite hard to use, I recall, at the time. The blood testing strip with the colours took about a minute to work. But at the beginning, I recall things were quite easy and my blood sugar levels were okay. They were in the right level, the correct level. About 6 months later, I noticed that these started to increase higher and higher and higher. And my belief at the time was I was doing something wrong. I remember feeling quite scared of my consultant, actually. She was probably lovely, but she intimidated me. And before I went into the appointment every 3 months, I would fake the numbers here on this chart because I didn't want to be seen as a failing diabetic. We'll talk a bit about language in a moment. Often people with diabetes have a honeymoon period at the beginning where they produce a bit of insulin themselves, and that can help even things out. That was my initial experience as a young child going into my teenage years. In order to control blood sugar, of course, it's not just about the insulin you inject. There are all sorts of things that can raise your levels of glucose in the blood. Carbohydrates, protein, coffee, exercise and stress. Waking up in the morning creates a rush of glucose, if you like, into the blood, and this is picked up on your blood tests. The site or the insulin might fail, it might have got warm, you could be tired, and you could particularly be stressed or exerting yourself mentally. All of these things push your blood sugar level higher, which we'd like to avoid. If our blood sugar level is high, we can feel in the short term tired, lethargic, angry and stressed. Long term, it leads to the conditions that the complications I mentioned earlier. On the other side, lowering your blood sugar is, of course, your insulin. But exercise, stress levels, alcohol, fatigue, mental exertion, again, and the observant amongst you might see that there are items on this list that do both. What chance does a child have at that point, or anybody, in fact, to balance these things when there are just so many variables? I'm a physics teacher, not a biologist. I'm not an expert in diabetes or the pancreas or insulin or the response. I just look at the effect on my body. But I do understand graphs and I do understand numbers. And when there are so many variables, it makes life very difficult. If you imagine your day across the bottom of this chart and your blood glucose across the side, this represents a 24-hour period. The numbers on the left represent your blood sugar level. Here in the UK, we have a unit, we shorten it to millimoles. In Europe, America, and most of the world, you have numbers that are often in the high tens and hundreds. And this is just a different scale. It causes no end of confusion between members of different diabetic communities across the world with these numbers. But we're going to use the British system because it's what I'm used to. You multiply it by 18, you'll get the numbers used everywhere else. And you're told you keep your blood sugar level between these two values. This is what people without diabetes will find their body is able to do. So you wake up in the morning, you take a finger prick blood test, you put the blood on the machine, and you find that there's our readings of 4 to 8, where they'd like you to say your blood sugar level is high. So perhaps you give yourself a bit more insulin, and then you find that you're low by lunchtime, so you eat a bit more food. In the evening, you might be about right. Before bed, you're low again. And the decision you've got to make at this point is, what do you do? Do you go and eat food before you go to bed? Do you hope that that's going to be all right? Because the dangers of going low on your blood sugar level in the short term, sweaty, confused, some people describe it as looking a bit drunk, unconsciousness, and death eventually. The insulin that you're taking depresses your blood sugar level, which can result in your death if you are not aware of what's going on or you are unable to treat it because you're asleep. This is of great concern, and this is why often people with diabetes are known to be eating sugary things. It's because their insulin has lowered their blood sugar level to the point where they need to take some corrective action to raise it. In 2002, I was given 2 types of insulin, the first change in 10 years, a fast-acting and a longer-acting insulin. I'll give you some science here, but you don't need to know about this really for the rest of the talk. But one insulin lasts for 12 to 18 to 24 hours, and the other one you take with food. If you eat more food, you take more insulin. If you eat less food, you do less. And at this point, I went off to university, which is not the ideal time to be changing your diabetes regime. I found it particularly difficult to manage. The lack of education, the lack of training in how to work out exactly how many carbohydrate grams were in each food source was of particular concern. And in 2011, after 10 years, many days where I didn't test my blood, I just based it on how I felt. I struggled, I think, during those 10 years. No major disasters, but I think that's more through luck than judgment. And injecting 6, 7, 8, 9 times a day in hope more than anything else is quite a scary prospect for anybody to be in. And that is the reality for many who are on this system called MDI, multiple daily injections. 2011, I was granted a week off work and given access to a course called Daphne by Miss Lee, who granted me the week off work here at King's. Daphne is a week-long education course where you are taught how to manage your insulin for normal eating. Now, I'm not quite sure what the definition of normal eating is. The picture here, the logo is a biscuit, which seems an odd choice to me. But I was incredibly grateful for this, and it was the beginning of my journey into becoming awakened by my diabetes. And this was really the start of my journey. In 2014, I was granted access to the Freestyle Libre. It was a new method of measuring your blood glucose level. Theresa May wore one, and you may recall this being in the news at the time. Many people thought it was a nicotine patch. Hormone contraception was another suggestion, and other insulting remarks about where they plugged her in the evening. You can look online, you'll see all these comments, but it was the Freestyle Libre, and it is a method of measuring your blood glucose level. You attach that to your skin for 2 weeks. It sits just under the surface, measuring the glucose levels in the interstitial fluid. That's just outside the blood vessel, so you don't need to penetrate into the blood vessel. And you are presented with a graph every time you scan on your arm. I'm wearing one right now here on my left arm. And instead of getting these dots, you get a graph. And the graph, of course, gives you so much more information. It shows you trends. The analogy I'll give you is a bit like driving along the road, only opening your eyes maybe 4 times along your journey in the previous blood glucose finger prick method. If you open your eyes and you're in the middle of the road, you might think things are okay. But if you're driving off to the hard shoulder, which the graph trend line will show you, then you know that you need to take some corrective action. What's worse, sometimes you do the wrong action, and if you think you're heading in the other direction, and this graph can really help enormously. And by doing this, I found that I was going quite high every morning, every single morning. And after getting up at 4 a.m. to inject insulin, I really couldn't cope with it anymore. I ended up taking about 15 injections a day, trying to finally balance this system. And my consultant met with me and granted me access to an insulin pump. A minority of adults in the UK have access to an insulin pump, but it really was the solution I was looking for. I remember feeling quite emotional when I was told that I would be able to access this equipment, this life-saving equipment. An insulin pump is a device which you attach to your skin, or rather you attach it through a cannula just under the skin, a few millimeters in, 5 millimeters probably, and you change it every few days. You fill the pump with insulin, etc. Notice the picture, by the way, just as an interesting aside. Part of this journey has been the diabetes community reaching out to each other and talking a lot more. And this stock image here is the same one used for about 4 different insulin pumps. They just changed the picture. And it was commented that it's not particularly representative of people in general. And you'll notice that in a later video showing you how to attach the insulin pump, they've used a perhaps a more realistic model. This is the insulin pump I'm using, and this is the company website and how they recommend you attach it. Now, the insulin pump runs an automatic program that you tell it, and you edit this every so often. And it runs this regardless of what you're doing. You press buttons when you eat food to give yourself a boost. But as you may notice, the same problem arises as right from the beginning. If you're following a path, a rigid path like this, then life throws all sorts of variables at you. We are not able to treat this condition with the immediacy that it perhaps needs. Now, at this point, I had the Libra sensor on my arm, and I had the insulin pump attached to my side. Mine currently is just on the side here. I would scan the pump, apologies, I'd scan the sensor, get the reading, and plug it into the pump and see what it suggested. There was absolutely no way of these two separate companies' products talking to each other. It was only through me and pressing buttons all the time, day in, day out. And the question I asked at the time is this really the best we can do? Now, in America at the time, actually a few years before I started using it, there was a conference in Stanford University, 2013, where many people, this is a photograph from the conference, people from all sorts of diabetes backgrounds, university researchers, some companies, patients, doctors, got together and started discussing this issue of data interactivity between different devices. They created this hashtag, which they added to describe the problem with the system as it currently stands. Individual data islands, as they were referred to, regulators needing to regulate, competitors to cooperate, for payers to pay, peace of mind for children. This is the key one for me: get data off devices. I was unable to do that unless I did it manually. And finally, they said that they're not waiting for the cure. And that really struck with me when I found this out later, because I've been waiting for a cure, as you remember, 2003. I was told 10 years from my diagnosis. Incidentally, PWDs, if I get this wrong tonight, I'll explain why in a moment. In 2018, the NHS was approached by the diabetes community about the way in which it refers to people with diabetes. For example, the phrase diabetic was suggested to be outdated. You wouldn't introduce a child as a myopic, for example. I've always known myself as being diabetic or a-diabetic. However, the language has moved on, and I'll do my best to respect these new guidelines that people working in the NHS are given. There's a website, you can look it up, and if you search for this title, you can find the document. It really is eye-opening. It's very interesting. In 2014, we introduced this lady here, Dana Lewis from Seattle. She is a person with diabetes type 1 and is an incredibly heavy sleeper. She was fortunate enough through her insurance to be given a continuous glucose monitor, a bit like my scanner, but one that beams to her device. The device is just here in blue at the bottom. However, she's a very heavy sleeper, and she would never wake up to alarms, high alarms, low alarms, concerns, warnings. She would sleep straight through, and that put her at great risk. She questioned, why can't I take the data off this device to increase the volume, to alert my friends, my neighbors, potentially save my life? And she went about hacking this along with her husband, Scott. And she's not a coder or a programmer. She worked in IT, but not in a technical capacity. And they were able to set up Night Scout. It's a website in the cloud, so it can be accessed anywhere, all over the world, by anybody with a device that connects to each person's personal site. I've got a watch right here, which is telling me my blood sugar level is 5.5, and that's come straight from the internet, from Night Scout. My partner could wear a watch with it shown on. Anybody that wanted to, who knew my code, could do the same. And through collecting this data, she realized that this would help thousands of people, tens of thousands of people, more. And Night Scout began to be set up by people all over the world for their children, for themselves. The numbers were monitored in this way at work, driving along the road in dangerous situations, when it isn't appropriate perhaps to take a blood test with your finger prick. And even on its own, before I talk about anything else, this is revolutionary. This is incredible. Night Scout was the very first thing that began this whole process for many people. However, once you've collected all that data, once you've taken all the data, hacked into the Dexcom, it was for her, Dexcom servers, and taken the data and put it online, Dana Lewis asked, these life-saving drugs we're being given here are lethal, potentially. Too much, and you can find yourselves in all sorts of bother. So we need technology that adjusts in real time. And she has that technology, of course. She's wearing an insulin pump, which requires manual intervention throughout the day. But she did it. She set it up. She was able to hack into the insulin pump that she had. Took time and effort. Coders all over the world worked on this together. They were able to access the protocol, the communications of the pump, and they were able to make predictions. They developed an algorithm. They developed a mathematical code for predicting what will happen to insulin levels, glucose in the blood levels, food levels, and they can decide to instruct the pump, for example, to cut the insulin off if it looked like you were heading towards hypoglycemia, low blood sugar, below 3.5 on that scale. And this was phenomenal. Dana Lewis has become quite famous because of this. There's a Guardian article about her. You can watch her TED talk. You can Google her. She's written a book. I've met her, talked to her, and she's very active in bringing this to the world. And she is a wonderful inspiration for anybody that's interested in taking action to solve problems if the solution is not available to you. This was the kit she was carrying around: a computer, her insulin pump, her continuous glucose monitor, a battery for the little computer, and a radio link to talk to the pump. It is quite a lot of time, effort, and investment went into creating this system here, this artificial system. But it worked. If you look at the graphs on the bottom, you can see the vast improvement in her in-range time on those moments which she is presenting them there. And the algorithm, the computer code, all of it became known as OpenAPS, open being free for everybody, open source, anybody can download it, anybody can amend it, anyone can develop it. And OpenAPS really is a wonderful thing, which I'll now lead on to talk about. This is my journey. This picture was selected by Sue Tingle tonight for the poster. You notice my hair is slightly different now, and I look much younger and less grey there. But the irony of this picture is it was taken a week after I started using OpenAPS myself in April 2018. So I don't know whether that's a smug look on my face there from being very excited, very happy with what we were doing, but it's a particularly good picture to have chosen completely by accident. At this point, remember, I was having to manually put in numbers into the pump, and the pump was reacting to what I decided. Is this really the best we can do? Well, the first thing was I didn't want to keep scanning my Libra sensor, Abbott Libra sensor on my arm. A Chinese company known as Meow Meow invented this device about the same size as the sensor. It's about the size of a £2 coin, which goes over the top of the sensor and continually reads the values every 5 minutes and beams that to a mobile phone. Absolutely incredible. So you plug it over the top of your sensor, Bluetooth it to your phone, you upload it to the cloud, to Night Scout, and then you can access it on your watch just by glancing. Also, anybody else can access the information too, of course, which is particularly useful for parents with children or people who would like it for their partner. When I did this, I discovered just how bad, at my point, even though we mustn't use the word bad, just how, well, in my opinion, poorly controlled my blood glucose level was. Nearly 60% above target, nearly 4% below target, potentially hypoglycemia, needing treatment with glucose, sugar, food, whatever. An HbA1c, which is the standard of judging your diabetic care, your treatment, of 8%. You'll see later that that is in the red zone on the picture. And this is the graph of 3 weeks. The black line represents the average glucose level. You may remember those two bands showing you what is considered to be optimal control. You'll notice that there's peaks and troughs. Usually these correspond to post-meal time. And overnight, where I couldn't intervene, my blood sugar level often trended rather high. So what could be done about this? Well, I actually discovered Dana Lewis on The Guardian and read her article, if I remember rightly. And I found that building a pancreas was not beyond me at all. You need a continuous glucose monitor. I had that. You need a pump. I had that. And you need the code, the algorithm. Well, I had that too through Dana Lewis. The other things I could buy quite easily. The issue is, of course, I probably didn't know how to do it. Didn't have the battery or the computer. I didn't have the technical ability, the understanding, or indeed the support of the diabetes team or the consultant who worked with me. Unfortunately, when I looked into it further, I realized that the insulin pump I had, this one here, the newer version owned by a company called Medtronic, had locked out the remote access because of hacking concerns. So that was a change from my expectation of what I could do. But because there is an enormous community, Twitter, Facebook, of people with diabetes working together, I messaged hundreds of people and eventually located an insulin pump that was compatible with the supplies I was given by the NHS in South Dakota. Communicated with the owner, managed to get it posted to a friend of mine in San Diego, who then posted it to me here in the UK. And when it arrived, it was absolutely incredible. I ordered the computer, which was built partly by a person with diabetes in California, and also an Intel little microcomputer called an Edison. A friend of mine built the case, 3D printing case, and I assembled it. Because this is a very community-led effort, all of the instructions are provided online, all of them. They're there to access on the website of OpenAPS. I had to learn how to download code from GitHub, which is a place where you store your code, how to connect to my little Intel Edison computer using a software called Putty, built the rig, screwed it together. Considerations, of course, things that made me think twice. Do I trust this software? Will I resist the urge to intervene? Well, hold on a second. I need to remove that. Do I trust the software? Yes, pretty much. Safety is built in. If ever the software goes wrong, it defaults to your default position. Very important consideration. Secondly, could it be hacked? Remember that the code had been removed from the insulin pump. It was a consideration. What about hardware failure? These old pumps, out of warranty, no consideration whether it would be possible for it to work long term. Many of them crack. They're about 15 years old, daily use. Think of how long mobile phones last these days. The computer failed at one time. Intel Edison was no longer manufactured. So there are alternatives. This is one I tried to build. The company that makes the watches that I'm wearing now, the Pebble watches, was bought by Fitbit and they shut them down. Great concern in the diabetes community for that. What about software failure? Nightscout is stored on the cloud. The company, Heroku, where it's stored for free, decided to suspend huge numbers of people's accounts for violation of the acceptable use policy. And at that point, of course, your treatment plan is in tatters. How would you manage that? How do you deal with it? What about the batteries? They're LiPo batteries. They often, hopefully not, but can catch fire or expand. Great concern. Are you going to be able to keep things charged up? What about communicating between these devices? What about fine-tuning and updating it? And on and on and on. What about my support from my consultant? Nevertheless, I set up the software. I downloaded it to the Intel Edison computer. I recall this moment where I had to choose whether to press continue, yes or no. I remember where I was in Derby. I went to Rolls-Royce in Derby to speak to a team of about 7 or 8 people that had decided to get together to work on this. And I remember this moment, how exciting it was when I installed it to the device. And the code started to function and it took control of the pump. Now, at this point, we have to remember just how life-changing this is. I was able to sleep for the, well, it's the first time in years to be able to go to bed at night knowing that if my blood sugar level was dipping low, then the pump would turn off the insulin delivery and it wouldn't keep injecting it into me regardless. This is so incredible that it's very hard to remember a time for me now when this didn't happen. That stress in the back of your mind is able to be relieved somewhat, and that makes a huge difference to your life. Here is a graph of Night Scout, and this blue line represents the insulin delivered by the pump, the number of changes higher and lower below the dotted line of the default position in order to make the diabetes blood glucose level change in the way that you need it to change. This shows the average glucose level before and after I allowed the rig OpenAPS to start raising my insulin level if I was high, lowering it if I was low. And this graph, 3 weeks before, became this, 78% in the green zone, with a huge reduction in low hypoglycemias. Even more remarkable, this chaotic graph of manual decision-making became this. Not perfect, but the key point to make is at 8 AM every day, I would wake up with exactly the right blood glucose level, because of course, overnight, the only variable is what the pump's doing. And it is able to get you into that range, for me anyway, every day, perfectly. To start in range, of course, means I'm a better employee of the school, better housemaster here of the Grange, better partner, father. I'm able to begin each day, at least, in the right frame of mind. It's like having a good night's sleep every day. Now, truly life-changing for me, truly, truly life-changing, reducing numbers of decisions, reducing stresses. And in doing so, I was able to meet with all sorts of people. Here's the code running on the right-hand side here. Who is this suitable for long-term? What role did the NHS have in this? They gave me the pump, but I was very scared to tell them what I'd done with it, actually. And the fact that I was using a really old one from a lady in America, genuinely was taking this on myself at the time. How far can we trust this technology? And should this be commercialized, regulated? Very much is a do-it-yourself approach. You have to build it yourself and deploy the code yourself. You can't download an app. You can't get someone else to do it for you. It's critical to the design of this system. You often see this hashtag YDMV, your diabetes may vary. It works for me, may not work for you. And what we try and do is very much on a case study of one person at the moment, everybody individually. But the results are quite spectacular across the world, and the hundreds that have used this. Reduction in blood glucose level averages, reduction in hyper and hypoglycemia, quite significantly in country after country after country where it's been used. I've met loads of people, these three here, one of them being me on the left. All of us met together in Manchester, all put the rigs on the table there, and it just worked incredibly. And it was fantastic to meet these people I've been working with online. I actually got a like from Dana Lewis, which I was particularly excited by. This is before I met her. It shows how interconnected this community is. I attended a conference in Scotland where I heard various people talk about their excitement, including many people who work in the NHS. There's some key characters who are pushing this forward and developing it. There's a project with Cambridge University which has been released, and clinical trials are ongoing, and people are given access to a version of this. It is really, really, really exciting. This picture was from before that started in 2019, I believe, in the autumn. So what's happened since? Well, pump after pump after pump has had its controlled protocol broken. In other words, we can now send commands to it, including on a device like this, which uses purely Bluetooth. I have it in my pocket right now. And this insulin pump is controlled by an app rather than it being on a little computer device. Android APS, as it's known, uses exactly the same code as OpenAPS, except it goes onto an Android phone. You make the file yourself, very simple to do, follow the instructions, and you install the application onto your phone. The Libra blood glucose scanner recently became upgraded, so it has its own Bluetooth capability, removing the need for the meow meow at all on your arm. Again, that took a bit of work by the community. It wasn't originally like that, but they were able to crack it. So the technology burden has been reduced over time. I can replace my phone. I can replace the meow meow device. So it's just talking directly to the phone. And my new pump means I can get rid of the computer altogether. And I now have my smartphone connected to the pump. And up to November last year, I was plugging in my food, plugging in whether I was needing more insulin, I thought, and it took the burden of the rest of the decisions overnight and after meals, etc. Question was, what next at that point? What could we do? Where could this go? Well, here is a picture of my blood glucose level using the insulin I was using. And 2020, new insulins came on market, faster insulins, insulins that would react not 30 minutes, not 60 minutes after you were to inject or bolus them, as we describe it, but would react in 20 minutes, in 15 minutes, in 10 minutes. Fiasp was one. I tried that. I didn't get on particularly well with it. And Liamjev, interesting name, was the insulin I started going to use in the summer of 2021. And I found there were days when I didn't do anything at all. I was going about my business, forgetting to input carbohydrate choices, forgetting to bolus. And I get to the end of the day and look at my graph on my phone and say, I never went out of range today, and the app controlled everything. And this is quite remarkable. This to me was as close as I could get to a cure. Could I go all day without plugging in numbers, without worrying about what I was eating particularly, and without making adjustments? Could I let the algorithm, the app, do it for me? Well, it turns out there were people thinking about this. Tim Street, one of the programmers, the developers, discussed this on a Zoom call. And Mathieu here at the bottom right had actually been amending the code, increasing the capabilities, allowing it to give more insulin, amounts that were beyond the safety limit, actually. And I questioned in November last year what would happen if I allowed this app to take control. If I decided I wasn't going to touch it at all, and I was going to see just what it was capable of doing. So automatic closed looping. Is it possible? Well, I didn't know him at the time, Matthew, and I decided to contact him. I found him on Facebook. We engaged in some really interesting conversations. He invited me to the Discord chat. For any gamers watching will know, I think that Discord is a gaming chat site. Apparently, I signed up to that. I felt like a bit of an interloper. And I was given access to the code, which I was able to download. Remember, I'm not a coder. I understood what was going on, but I wasn't able to write it myself. And I downloaded it to my phone. And the first day, it was able to deliver the insulin I needed to keep me in the green without any instructions. The second day and the third day and the fourth day and the fifth day and on. You may notice the shape of this one is different. It's because I smashed my phone in December and had to go to a backup. But I found day after day after day after day, I was in range 85%, 90%, more, some days 100, without inputting anything, without touching the phone even. I could forget it was there as long as I was confident it was still working. This graph represents my blood glucose level as read by my sensor. The bottom graph represents the insulin that had been delivered. The yellow is the activity of the insulin. You'll see overnight, things are kept perfectly in line almost every single time. And in the day, when I'm eating, when I'm stressed, when I'm telling off boys of the Grange, I get stressed and then I go low and then I go, it bounces between those two limits almost perfectly. Here is a graph of an event. I'll just pause it for a second. At this point, I ate lunch today, and it was quite a sugary curry, I think, a prawn curry. It was very tasty with some rice. My blood glucose level started to rise, and the system started firing in the insulin. Blood glucose there, insulin on board here, increasing as you might see there, and the graph increases. I actually went above the range today, and it brought me back down. And you'll see as those predictions change that it has, without any intervention at all on my part, brings me perfectly in range. I'm very nearly finished. But I want to just show you that again. The rise, the increase in insulin, you can see it down here on this graph, all automated. At this point, the insulin is cut to 0. You can see the graph has reached 0 here. You can see the percentage given is 0 here. A bit like accelerating and then coasting in a car, getting just over the hill and falling down at a leisurely pace. And although that graph looks simple, this is over years and years and years of testing of patient data, all shared openly, and fine-tuning and tweaking of the algorithm. This is the graph, the pie chart of my last 3 months, 90% plus in target range, with virtually no hypoglycemia at all. And just compare to where we were at before. This by the way is the distribution. Quite remarkable. If you compare to where we were, this is without any looping at all, purely manual. This is with looping, but lots of intervention on the pump, getting in the way of it really. And for me, with the faster insulin, with the amended algorithm that is willing to make decisions to try to reduce the blood sugar from food that I have not announced to the system that I've taken, I haven't inputted anything at all for 3 months. And that is bringing me to as close to normal living as I possibly could be, or anybody with diabetes could be, in my opinion, until a cure genuinely is produced. And the most important thing, if given access to the technology, this is open to everyone. This is open to all, and it's free. So what's my conclusion? Well, time in range from 40% to over 90. My hypos have gone from 4% to less than 1, almost insignificant. My average, the A1C, the gold standard of testing, 64 to 42, you'll notice takes me from reasonable, I think, for being having diabetes into the normal range, whatever that means. My stress level has been reduced hugely. Risk of complications has been significantly reduced. I sleep well, I'm more active. I eat better meals because I think more about what I'm taking, whether my insulin can balance that out effectively. I now use my friends and colleagues and comrades around the world for my diabetes support. Before I was alone, I felt. Occasional help at the hospital every 6 months. Good help, but they couldn't see me as much as perhaps we needed. Now, if I post a question on Facebook, it is Facebook that we use, I'll get many answers within minutes. And in return, I help others in the same way. This is one of the most significant things about this patient-led innovation. I've gained huge confidence from this. I've realized you can't be perfect. Those graphs will never be perfect. And finally, anything along that journey is better than doing nothing. No matter what stage you get to, taking control of your own condition, diabetes in my case, is the only way to succeed and to live the best life that you can. What comes next? Well, for example, Partha Kar, NHS consultant, managed to get the Libra on prescription for nearly all people with diabetes all over the country. You see the postcode lottery that existed before 2021. He did that single-handedly through work. And he mentioned closed loops in March 2021. He was at that conference in Scotland and is heavily interested in technology for diabetes. The DVLA changed their rules to accept this. And it was published today that the HbA1c results of the UK population are the best they've ever been, I think, in turn, because of the access to technology. And there's the Institute of Clinical Health and Care Excellence research going on right now, which they're interested in our opinion. Now, there are many other things being developed from this. Cambridge are developing their own, and many people are on this. It works in a very similar way. It's based on Dana Lewis's work and developed from that. Really exciting, very interesting, very much less hands-on, but still very interesting. You may have seen some news last year about the trial of closed loop technology, and many other companies around the world. If anyone's interested, there's a book by Dana Lewis that you can read about how to set this up. Takes you from the very beginning. It's free, open for all, and there are various links which, if you search for "We Are Not Waiting" or OpenAPS or GBDOC, which stands for the Great Britain Diabetes Online Community, then you can find out some more information. And I'd like to thank you for listening to me. It was not long enough to really explain how all of this works, but it was really an attempt to pique your interest and invite you to contact me if I can be of any assistance. This is very much part of DIY OpenAPS, is that we help people to find out what might work for them. Thank you very much, everyone, and be happy to answer any questions.
Mark, I'm absolutely speechless. That was absolutely incredible journey of your life and what you've had to deal with. I'm inspired, absolutely inspired. I'll speak more about that after we get through some questions. Please type your questions in. I know we'll get lots coming in. Mark, can I ask the first question, if that's okay?
Yes, absolutely.
You showed those wonderful graphs of the blood sugar levels.
Yes.
What is dangerous? Like, I know it's going outside what we considered acceptable range. You were going really well above the blood sugar level you should have been. And what is considered really life-threatening?
I'll show you a graph then, if you like. You can see the screen just briefly. What the Libra showed me and many people with diabetes is that you, I'll just show it on that screen there, is that these numbers change rapidly, minute by minute. They change with daily activities. I mean, you can be hyperglycemic, eating everything in the fridge because you're shaking and you have this need when you have a low blood sugar, need to consume, and you always overshoot. It's about 3 jelly babies is what you need, but I would eat 4 bowls of Cocoa Pops or something. That's my go-to. And within an hour, you're at 15, 20, 25. I've been out with friends and I've done a blood test and found it's at 28, 29. Short term, apart from tiredness, lethargy, really awful mental state where you can't focus, the complications are what build up over time. I would suspect it's a bit like smoking, though I'm not an expert, that you build up your risk with greater and greater time above that scale. The lows are the real fear, where you could go low off the bottom of the graph or near to that level and fall unconscious, and death can occur from that. So the insulin helps you by reducing your blood sugar level, but it can kill you. And this is the balance that we need to find as people with diabetes, that you have to balance the long-term and short-term risks. But these numbers would shoot all over the place, absolutely all, and they still do occasionally. Things can go wrong. The pump site might become detached, or the insulin might go bad, or have a bad site where it's attached to, or it's a particularly bad day. But it's all about averages. That's what that HbA1c result is. It's your average blood sugar level. It's your average blood sugar level over the course of 12 weeks, I think, is the time scale. Just want to point out, this is not your average level of blood glucose level. This is a percentage. It's similar numbers, but it's not the same scale. Thank you, Mr. Hunter. Is that answers your question?
That does, very much so. Thank you. So we'll go to Daniel's question. Thank you for the wonderful, insightful talk, Mr. Orders. I want to ask about the nighttime insulin levels. What are the main difficulties in taking insulin at night for diabetics without pumps? And the cost of these newly developed insulins, is that an issue?
Hi, Daniel. Lovely to talk to you online. Daniel was in Grange about 6 years ago. I hope you're doing well. Yes, injections, so multiple daily injections. Let's remember that's what most adults in the UK use. And there are 2 types of insulin that one takes. One of them is a longer acting insulin. Levemir was the one I took. If I show you the graph, this is designed to keep you at a reasonable level, always having some background insulin overnight. So the idea being this injection would be exactly the right amount to guide you through the evening and overnight to prevent your blood sugar level rising. My insulin pump uses short-term insulin, and it gives it to me in little bits, and those last for maybe 5 or 6 hours, but you're delivering small amounts at a time. Now, if I ever pull the sensor, the attachment off, and sometimes it can come off at night, rarely, I wake up a few hours later feeling absolutely awful, headaches, almost a painful feeling across your body, and it's like it's inside. It's a very hard explanation. So insulin you need all the time to live, and it can either be delivered continuously in the pump or through longer acting injections and then shorter bursts to help you deal with food and carbohydrates. So the overnight thing, the fear is if you have too much insulin in your body, you'll start to go lower and lower and lower, and you won't realize. And that insulin will last in your body for 5 or 6 hours. And unless you've measured it perfectly, and unless you've dosed it perfectly to balance with the food you eat, you're locked in for the ride at that point, and you hope that you're heading in the right direction. I remember once, after a night at the Grange, I would have been a tutor on duty on the night when you were here, Daniil. I went home, drove home, and at 11 o'clock at night, I went to take my long-acting insulin, and I ended up taking the short one in error. An entire days of insulin, of quick acting. It was orange rather than green, and I just was going to bed and thought, I bet I've made an error. I feel like I haven't. I ended up getting to hospital and just being sat in reception drinking litres of orange juice, and my blood sugar level never came above 4. I might have died. Right? That's what I often think about. And when I talked about technology, do we trust it to take charge? Well, I trust it more with its safety features and its testing and its many users, hundreds all over the world use this system. I trust it more than my own lack of making an error. Daniil, you mentioned in your second question the serious quality of life implications of diabetics taking insulin at night. Well, without the insulin, you would become ill very quickly. So the nighttime is the dangerous part in my mind, because you have no chance of correcting it if you're a deep sleeper. And it's very much like driving with your eyes closed and hoping that you can continue straight until morning. That's a good analogy that I can give for you. I hope that answers your question, Daniil, but write to me if you want to get in touch with a bit further. Thank you.
Please, as we go through these questions, please don't hesitate. If you want to put your virtual hand up and actually speak directly to Mark, I will be more than welcome to do that. Tom has a question and a bit of a commentary first. Hello, firstly, Mark, I just want to say thank you for your interesting talk this evening. Really appreciate your candor, ingenuity, and engaging presentation. I'd like to ask how the pump tangibly helped impact your wider mental health, and whether you also experienced any wider physical benefits and unexpected ones. And you have sort of half mentioned that. Do you want to elaborate a little bit?
Yeah. So when I was granted the insulin pump in 2015 by my wonderful consultant here in Canterbury, who sadly died, he said, fine, we will give you access to the pump. And I remember I came outside and was nearly in tears, actually, when I came out of the hospital, 2015, because this is almost like a holy grail of diabetes treatment. It's a bit of a false one, because when you have the pump, you still have to manually make all these decisions. And in fact, you end up interacting with the pump more than your 6, 7, 8 injections. And many people expect when they're connected to the pump that it will do things for them. It's really just a tool, a blind tool, really, a way of delivering insulin in a more tailored fashion than a 24-hour injection with supplementary boosts, if you like. So I think any treatment is better for me than this, and I was incredibly happy to have been offered it. It's not something everybody can have. There are strict conditions. I was able to argue it based on quality of life. The waking up at 4 a.m. to try and deal with these spikes every morning because of the job I was doing here in the boarding house was a good reason. I'd managed to keep my blood sugar level reasonable, and by reasonable we mean under 8.5%. So it is a battle for some people, and it is a relief when you're granted this technology, because in my opinion it's essential. I believe it's essential. Unexpected physical benefits you mentioned. I'm mentally and physically fitter now than I was 5 or 6 years ago because of the lack of stress caused by trying to balance all of these. In terms of physical changes, I haven't really lost any weight. There's some people I think that's a wider lifestyle issue. But I think it's more the mental health and then the impact that has on your life. And this is the pump in general. As I said at the end of the presentation, anything is better than doing nothing. And I spent my university years and my first years working in teaching, getting through more by luck than anything else. Education and then access to this technology, which is increasing and improving all the time, is absolutely the way to improve living with this condition. And the second point is that taking an ownership of it myself, part of a patient-led movement, is also, in my opinion, the best way, because the NHS, supportive as it is, can't give you daily attention and can't educate you in the way that perhaps someone else with a condition can. Thank you. But write to me, Tom, if you'd like to talk more.
Thanks, Tom, and thanks for that fantastic explanation then, Mark. I'll sort of preface the next question with sort of how many people are using these, are you aware of, in the UK or worldwide, using this particular automated system? And one of the questions being asked, a relevant question there, is what's the age of the youngest child to successfully use this system? Because I can imagine for parents, for your parents, they wouldn't have been able to sleep much at all once they found out that you were type 1 diabetic. And now this could be just so life-changing for not only obviously the person with diabetes, but also the parents of the child.
My parents, I'm very fortunate to say, my parents let me get on with it on my own, actually. There wasn't the information. So part of the interesting thing here is that without the continuous glucose monitor and without the pump, you really don't have many data points to base your condition on. So I was doing the best I could with the information that I had, and that meant I had a lot of autonomy and independence. Now with the watches and the tracking and the continuous glucose monitor, parents are a lot more involved, and I think that's also a good thing. I think it's very important to find a balance. And of course, as a parent, my children at the moment don't have type 1 diabetes. It's not impossible that they'll get it. It's also not guaranteed either way. But I do know if they became diabetic, if they were diagnosed with type 1 diabetes, I would want them on this system immediately. In the UK, there are hundreds using it, possibly into the thousands now. When I started, there was probably 150, 200 in the world. I think it was quite inaccessible because of the number of pumps you could use. Whereas now, the Omnipod, both the Accu-Check ones, the Roche ones, the Dana RS pump, the Medtronic pumps, apart from the latest ones, all of them can be done like that. And you have babies on this system. If anyone, the person asked the question, go onto Facebook, find the Loops UK group and start talking to some parents on there, because they've used it from the beginning. In fact, a lot of this was driven by parents of diabetic children with diabetes. I don't know if you recall, when I shared my screen on the presentation, there was a picture of lots of children with the watches, and that is, well, there was one with about 100 different. It was a meeting of parents with their young children, and that is, there it is.
You're not sharing it, Mark.
Oh, I do apologise. Sorry. There we go. Thank you. Can you see it now?
Yep.
That is a picture of lots of children at a diabetes meeting point, all with these Pebble watches, all registering their blood glucose level. These people probably aren't looping, but they're just displaying the numbers, which is the first step towards a successful development of this program. So yes, there are now hundreds, if not thousands, in the UK, definitely thousands across the world, and children of every age, including children who are not old enough to do any of this themselves.
So part of my ignorance on this, Mark, if you've just got a little bit of cash and a little bit of get up and go to try and find it yourself, you can get onto this, or do you actually have to, is there some hurdle you've got to get through initially through the NHS? Or actually, can you just purchase this pump, purchase this, get a couple of things, and you're there? And
it's
so
actually, if we look at the UK example, because of our NHS system, access to insulin pumps is restricted based on need. If you are offered a pump, and most children are actually at the beginning, it's the way it works, different conditions, different criteria. If you get hold of the pump and you choose the right pump, then there's absolutely zero cost to you at all, because you can get the continuous glucose monitor provided on the NHS, the pump and the supplies given on the NHS. The pump costs about 3,000. The supplies are about 3,000 a year. These sensors are £50 for 2 weeks. So if you bought them yourself, I did for 5 years, just over 1,000 a year until they became funded on the NHS. It is possible to access it. Getting the pump is the key, and getting the right pump is key. And that is possible if you demonstrate that need and that awareness. That is not something I'm up to date with, because I was fortunate enough to be given it in 2015.
Just got a couple more questions.
Absolutely.
Two more mainly. Firstly, will the NHS help you set up the system? So,
yes, great question. Thank you. Now, I at the beginning was a bit nervous about approaching the hospital. I set this up in April 18, and I had my regular appointment in October, November 2018. And I went along with this blue cracked American pump, which was using the supplies, the identical supplies for the latest updated one that I was given by the NHS. And they approached me in the waiting room and said, "Oh, can we take your pump? We're going to download it." And I told them, "Oh, I'm not using it, sorry." And I then had all my paperwork, all my improved graphs, and I went in. And when I'm fortunate in that I was under the care of King's College in London. The reason I'm at King's College is because in Kent, they were unable to start me on the pump, financial reasons apparently, and I had to go to London, which I've stayed with. And they're a very innovative and exciting diabetes department. Professor Chowdhury, one of the key people pushing this system for people with diabetes here in the UK, is one of the consultants there. Now, they couldn't help me. In fact, they wrote a letter to me and my GP saying, "We're so impressed with this system that Mark's using. As you can imagine, we cannot recommend, advise or support its use. However, we can facilitate by not cutting the funding for the supplies." Different people have experienced different things across the country. So the NHS have, some of them have openly hostile and had to encourage the patients to write a letter, a disclaimer saying, "We will not hold you responsible for if you kill yourself using this system or cause yourself severe damage, and we cannot support it, though we won't stop you using our pump." Others have been incredibly supported, and others are completely ignorant. So depending on the level, I don't mean that in a critical way, I just mean this is so new and so innovative that our hospital and our NHS healthcare professionals, that's the word I'm looking for, HCPs, perhaps are unaware, and education will be the next thing. And that's why when I went to Edinburgh to the conference, it was so exciting that there were some really forward-thinking, interested parties there. So you can get support, either secretly in terms of not officially, but also this is something that one has to do by yourself, with the support of the community, at whatever pace you like. But there's a mentor scheme on the Loot Facebook group. I'm one of the mentors, and you can pick someone that you'd like to help you. And I've given hours and hours and hours of time to various people, phone calls, video calls, just talking them through it and letting them go at their own pace. And we've got people now using it who then are helping others. So the NHS is there to facilitate. That's the word they use. They're there to facilitate, but not necessarily to do it for you. And in my opinion, that's the way it should be anyway, with a condition, patient-led rather than to blindly doing what you're told. Thank you.
I agree. And the last question from one of our colleagues, Elizabeth. This setup sounds fantastic. And does having an implanted pump restrict your life in any way?
So you may notice on those diagrams that the tech I had to carry around, the phone, the rig, the batteries, all this stuff has been reduced. So now I've purely got my phone with the app on, the sensor on my arm, which is a £2 coin, it's just there, and the pump, which is in my pocket, and it can be detached. It just sticks into my side here, and I can take it off, and here it is. And every 3 days, I change its location. Does it get in the way? Well, it's waterproof, but I take it off to shower, take it off to bath, I take it off when I'm getting changed. If I'm doing football, I take it off. You can cope without insulin for an hour, hour and a half, 2 hours at most, probably. I wouldn't recommend 2. But the great thing about this system, of course, is I can tell my phone, like, taking it off, and then as soon as I put it back on again, it starts to catch up with itself. If I show you the graph from today, that's today. So that meal that I showed you the picture of is that little yellow bump on the left. And since then, we've just gone pretty much in the green as best you can. That horizontal line is the target. It is absolutely astounded. Absolutely. And I just got a message from one of the developers there about the new thing, talking about the latest update. It's been updated twice already today, which is quite exciting. Yes, thank you, Elizabeth. But it is something you get used to, just like, I suppose, any other essential item that you need to carry around you, like your phone. You know, does your phone cause you a great deal of restriction being in your pocket? No, interesting. Thank you for the question.
Mark, everybody will be giving you a standing ovation at the moment. Thank you so much for sharing your personal journey, sharing your story with us. I can say now, I mean, I'm a good colleague of yours, close colleague of yours, that in the physics department, we're both in physics department, and you know, I've always thought you're a wonderful teacher and inspiration, and now it's elevated to unbelievable levels. And I really do believe that those in the Grange are incredibly lucky to have you as a housemaster.
Thank you, Greg. That's very nice of you to say.
Incredibly lucky, and we're lucky to have you at King's. And you know, just a few points I want to say. Just hearing you cope with the challenges, overcoming the obstacles in getting to that final stage, is just been amazing. And also and I think it's a real life lesson for everybody there about taking control of your own health and well-being, not relying on other people or blaming other people. Be proactive. Decide that you're going to make the difference. Not rely on that NHS or that doctor, that prescription. Not to rely on those drugs in order to get yourself better, but actually try and do it yourself. And you're just given everybody tonight the absolute inspiration to go in that direction. So once again, thank you so much, Mark. I look forward to seeing you in the physics department tomorrow. And thank you so much for everybody joining us tonight. And have a good night. Thank you.
I'm just going to put up, Greg, for a moment, these two, the email address and the groups, okay? Because this is where to find further information. And I'll share this presentation somewhere, or email me and I'll send you a copy if you like. OpenAPS is is the source of all the code. Diabetech is a fantastic website run by Tim Street, beg your pardon. And by all means, write to me if you'd like further information, or find it for yourself on Facebook, where you can find me on there as well, or other people to help. Thank you.
Thanks, Mark. It's been an absolute pleasure, and thank you everyone for joining us, and we'll see you soon. And please don't hesitate to get into contact, Mark, if you've got any questions. Thanks very much. Good night.
Thank you.